So, welcome you all to Project Echo. Today is October 1st, and today's agenda, we will have just our usual introductions and brief announcements, and then our discussion for today will actually be presented by Dr. Alfaro Cruz. Dr. Alfaro Cruz is a pediatric gastroenterologist in Northeast Tennessee, and she will be discussing hepatitis C screening in adolescents. We will have two case presentations, and then, of course, an opportunity for any questions and an answer session. As always, if you are interested in receiving a continuing education credit for attending Project Echo session, please do not forget to register through the Southeast Age and Education Training Center. Kimber has dropped the link in the chat, but the link is on the screen as well as the QR code. It is not a requirement to participate in Project Echo. However, if you do want to receive that credit, you do have to register through SEAETC. So I do see that we still have some folks joining. Welcome everyone again to Project Echo. We are just going to move forward with a few introductions and announcements, and we will have some folks trickle in, of course, as we continue. So as always, please introduce yourself in the chat. Put your name, your role, your organization. If this is your first Echo session, please also note that if you do have any technical issues during today's session, to please reach out to Kimber Miller. She did put her information in the chat at the very beginning of the session, so please don't hesitate to reach out to her. I also want to add, while you all are taking time to do this, that I did recently encounter or was made aware of a situation with registering for Project Echo through the iEcho portal. Um, if Obviously, if you're here today, you've been able to register successfully. But if you are aware of any colleagues or staff that may have been trying to register over the last few weeks or experienced some difficulty, um, please note that the situation has been corrected and you shouldn't have any issues moving forward with registration. But if anyone does, please do not hesitate to have them email me at echo.tn@tn.gov, and I can look into that situation further. All right, so to kick off today, we're just going to, of course, start with a few icebreakers. The reason we do this is just to encourage you all to participate and also to let you know that this is an all teach, all learn environment. We want you all to engage, and coming off mute is always welcome, but we definitely want your participation in the chat. So just know that we encourage discussion. So, right off the bat, if you could own any animal as a pet, what would it be? A Komodo dragon, Candy. I did not picture that one. A Highland cow, yes. A baby monkey. An otter. Oh my gosh, yes, I love otters. Oh, I saw on social media today that this rescue group, they were trying to teach baby otters how to eat apples. Oh my gosh, it was the cutest thing. A kangaroo. They're so cute and it's so unique, that whole pouch situation, but I would almost be afraid they would like knock me out in my sleep or something. They're very strong. Dr. Allen, a red panda. Yes. I think the Knoxville Zoo, if I'm not mistaken, just had a couple of red panda cubs. My most unique animal that if you really know me, then you know that I literally have like a zoo. But the most unique animal I've probably had was a llama. and he was my pride and joy. I loved him. Unfortunately, he passed away, but hands down, probably the best animal I've ever had. Oh my gosh, Melissa, are you serious?
Her house backed the zoo, and the she I guess cooked with her windows open and stuff, but she'd get a phone call. My dad was telling me this because he stayed over there all the time. She'd get a call, Miss Cox, are the monkeys in your backyard again? And sure enough, they would be.
That's hilarious. I would enjoy watching that capture, I think. All right, so we'll move forward to the next one. So, if you had an opportunity to compete in the Olympics, what sport would you compete in? Bobsled. Yes. Track and field. I'm curious, those of you all who are selecting some of these, do you have any experience in them? So, for those of you all that see Kimber's comment about diaper changing games, our program had a meeting recently where we got together and we celebrated one of our coworkers who's having a baby, and we had to participate in a diaper changing game where you were blindfolded and had to put a diaper on a teddy bear. Hilarious. I think there was like at least two or three people that they wrapped arms, like the slot in between the arm and the leg. It was really funny. It was a lot of fun. Yeah. Yes, but nowhere near that level. Ice skating. I always like love watching ice skating. It's one of my favorites, that and gymnastics. And ice skating, they make it look so effortless. And I don't know if y'all have ever tried it before, but it's like my ankles just buckle immediately. I mean, there's just like there's not even a room for improvement with ice skating. It's just failure. All right, so these were fun. I hope you all enjoy these. I hope it kind of encourages uh, some discussion. All right, so the final one. What is your favorite dessert? And it doesn't have to be something on the screen, obviously. Lots of cheesecake. Banana pudding, yes. Ice cream. Cream brulee. That banana pudding was good. And I feel like it was like legitimately homemade. Like it wasn't instant. I pretty much love all of that y'all put in there. And I don't know about you, but like ice cream, yes, it's good in the summertime, but I don't know what is wrong with me, but I always want it when it's like below freezing outside. I'm like, ooh, I could really go for a milkshake right now. I don't know why. Homemade ice cream is delicious. Well, I appreciate y'all who commented in the chat and participated. And I am going to go ahead and move forward with passing it off to Dr. Alfaro Cruz, and she's going to present on hepatitis C screening in adolescents.
Hi, good afternoon, everyone. We are in October, so that means that for me, it's we are getting ready for Christmas. So, but no, I'm happy to be this afternoon with you guys here. So we're going to talk about Hep C screening in adolescents, and you're going to hear a lot of kind of overlapping with kind of because this is an interesting population group because it's kind of there in the gray area zone where they're still not considered adult and then we're not consider them as children per se. And they kind of have a lot of characteristics from both populations. So we'll talk a little bit more about that. But I think this is a very interesting topic to talk about in that sense, so we can learn more together about it. So next slide, please. So I have no financial disclosures or conflicts of interest to report. Next slide, please. So the objectives of these talk is that at the end, we're able to identify some of the risk factors in adolescents that may lead to hepatitis C infection, to recognize the difference in screening in infants versus adolescents, and to recognize the importance of STD counseling in high-risk populations, including adolescents. Next slide, please. So we have talked about kind of Hep C in infants throughout these whole series for the past few years. We already know about perinatal transmission being the most common risk factors or the most common form of transmission for infants. We know that the incidence goes from 1 to 7% in infants born to Hep C RNA positive moms, that it also will depend whether the mom has a untreated HIV co-infection as well, as that will increase the risk, and also depending on how high is the Hep C viral load in the moms, right? Now, with adolescents, something interesting happens because we know that the prevalence among children, the prevalence of Hep C among children, it's actually higher in adolescents than in infants. And we know that there is a very increased factor associated with some of the behaviors, either sexual or use of IV drugs in adolescents. And one of the things that the studies, and these are old studies, and we're talking about 2012, 2015 studies have shown that, especially in the states of Kentucky, Tennessee, Virginia, and West Virginia, there had been a substantial increase in the number of acute Hep C infections among people between ages 12 to 29. But that's the interesting part, that we're not just talking about adolescents between 12 and 18. We're expanding those groups into those young adults or that group between 19 to 29 years old. But we have known that at least uh, of the amount of people that do have Hep C, 78% of those had the risk factors of using IV drugs. And so that is something that is always going to be a risk factor in this population group. Now, whether you think, oh no, 12 years old is too young. No, we have to be honest and realistic. As someone that sees pediatric patients all the time, I can tell you that you would be surprised how early in age or how young these kids are starting to use drugs, and not necessarily IV drugs used, but it can be marijuana, it can be ecstasies, it can be all these type of drugs that we really don't expect, but we have to be suspicious and we have to start thinking more about that. So we do know that the few prevalent studies that we have are pointing that the adolescents are more at risk because of the use of IV drugs. Next slide, please. So when we say the difference between the infants and adolescents, we know that when we talk about screening, every child born to a mom that has Hep C will actually be screened. And we'll talk a little bit more about the screening and just kind of do a little bit of a refresh on that. But we know that they're going to be screened no matter what. If they're born to a mom who had Hep C, time of delivery, we'll get screened that baby. Next slide, please. But usually in adolescence, and this is where it kind of going to overlap a lot with adolescents and children, right? Is we're going to have other kind of risk factors that are going to lead for us to say, yes, we need to actually screen, or you have to think about potentially these can be a Hep C infection. Especially if you have a child or an adolescent without actually a clinical evidence of hepatitis, meaning by significant increase of AST and ALT. So part of your workup in these children or adolescents are going to be regarding testing for Hep C if you find this. Now, also some of the things that you will see is that a lot of our teens, preteens are also dealing with obesity. And that can also lead as part of the evaluation that they were going to present with elevated ALT and AST. So as clinician, it's going to be very important from our standpoint to actually get a very detailed history, physical, family history, health history, surgical history, in order to make sure what are these risk factors and if these increase in AST and ALT are associated with Hep C. As we said, all children born to a mom living with Hep C, sometimes some of these kids are missed for follow-ups or kind of fall into the cracks, patients moved. And so the concern that if there is a sibling that had Hep C and the other sibling has not been tested, and is at the same mom, they need to be tested, no matter what's the age, especially if that patient itself has never been tested before. And that's where it goes to the next step, right? Siblings of a child with Hep C from vertical transmission if born from the same birthing parent. International adoptees and refugees. We have talked about these before as well. In our system, all the moms, when they get their prenatal care or when they come in and they have not had the Hep C screening and they're about to give birth, they get tested for Hep C. Now, that's not the case for a lot of other countries or third world countries where they actually don't test the moms for Hep C. So this is something that's going to be very important. And this is going to be regardless the age, right? Regardless if it's a child or if it's adolescent. Children and adolescents living with HIV. We have been very good at screening for HIV and treating HIV. And a lot of our adult patients who have HIV and have a co-infection with Hep C receive treatment. But remember, not only because he's a young 12, 13, 14-year-old, you cannot dismiss that HIV is a possibility. So any child or adolescent that you know has HIV needs to be screened for Hep C as well. Victims of sexual assault, sorry, victims of sexual assault, regardless the age they have, they are going to need to be screening. And that's going to be part of an important part of evaluation once it has been identified that they have had they have been sexual assaulted. Individuals who actively using drugs, IV drugs, or they report using any time in the past any use of IV drugs, especially in adolescents. Think about that number. 76 to 78% of the kids of the adolescents who have been diagnosed with Hep C have had some use of IV drug use. Next slide, please. Now, the ones that you saw in the previous slides are kind of the most common ones, and you have to keep in mind. The red ones are the ones that kind of overlap among children's. Now, when we're talking about adolescents, there are other factors that we have to consider or other risk factors that may lead to screening as well. Children and adolescents with intrafamilial exposure, especially in the family members, if there is concern for sexual abuse or anything, or other family members who've had Hep C. And we'll talk about the use of actually razors, scissors, things like that. Then you have to think about screening for Hep C. Adolescents who are incarcerated in correctional institution too. There is an increased risk and there's associated with the risk factors as well. So they will need to be screening. Adolescents who receive tattooing and body piercing in unregular settings. And that's where kind of it's related to correctional institution or places that are not accredited or do not have safe practices when they're doing tattooing and body piercing too. Who use or inject illicit drugs in recent or in the past, including those who will tell you, "Oh, I only did it once," and they do not consider themselves a drug user, then you have to screen them. I usually talk to my adolescents about even if you only did it once, it can happen. A lot of our patients or a lot of adolescents think, oh no, I only did it once. I had unprotected sex once. We have to provide education to them that even if it only happens one, you can be at risk of getting Hep C, of getting HIV, of having an unplanned pregnancy. So that is something that is going to be very important when you're talking with the adolescents. Take away the stigma that, oh, it just one time, it doesn't mean it's going to happen. No. Sometimes that one time that they use, the needle may have been infected or they may have contracted HIV or Hep C. So that's going to be very important to discuss with the adolescents. Next slide, please. So this is what the United States Preventive Service Task Force talks about it. And they really don't have, and this is kind of where it comes important because we really don't have specific guidelines of when do we test the adolescents, right? We have risk factors. We have the clinical suspicion that's going to lead to you say, yes, I'm going to screen you. I think you have enough risk factors. I want to make sure you don't have it. But when we talked about kind of implementing nationally, we know that the USPS task force tells you we need to screen at least one time in their life for Hep C adults between the ages of 18 to 79. And that includes pregnant women. Now, yes, the guidelines also specify that any pregnant individual, even if she's below 18 years old, should also be screened for Hep C because of the increased prevalence that we have been seeing on actually perinatal transmission, as well as mom who use more IV drug use, right? And so this is kind of the important part because when you go to look at the guidelines, nothing talks specifically about what you're going to do with that adolescent between the ages of 12 and 18 or between 3 years old and 18 years old. So your suspicion has to always be based on the clinical factors that you're being presented and also the risk factors that that specifically individual presents when you're getting your information. Next slide, please. Now, what do we do, right? We know kind of what are the risk factors. We know we're going to screen the patients. So what's the difference between what the test that we're doing with infants versus the test that we're going to do with adolescents or children? So we know, and we have talked about these, that when we have an infant who was born to a Hep C infected mother, they are going to get their screen. And ideally, we wanted to do these as soon as, or as early as 2 months of age. Usually those kids come to their well child appointments at 2, 4, and 6 months. And we have the opportunity at that time to get their Hep C PCR RNA during those appointments. Now, we have discussed this, right? Like if it's negative, perfect. You don't need to kind of continue doing the follow-up. Based on our recent studies, based on CDC guidelines, based on the Tennessee Department of Health Tennessee guidelines, that that kid does not have Hep C. If the kid presents between the ages of 7 to 17 months of age, then you're going to do a Hep C PCR RNA testing or the NAAT for Hep C virus. And again, if that is negative, then perfect. You know that there's no infection. If it's positive, you're going to continue following that patient. Now, and this is going to apply for everyone. If that child is more than 18 months old or 18 months of age, and they have not been previously tested, then you're going to get antibodies Hep C with a reflex to Hep C PCR RNA for confirmation. And that's going to be according to the guidelines from the CDC and the Department of Health, the Tennessee Department of Health. Next slides, please. Now, what happens with adolescents, right? So in adolescents, and when we look at these slides, I kind of want you to take into account that you're going to look at the risk factors. And those risk factors are going to be, are they sexually active? Do they have multiple partners? Are they using IV drugs use? Is there any concern about potentially this patient has had an HIV co-infection or has had exposure to the virus? So they usually will get the antibody testing first. And that is going to either go, if it's negative, then you know that if there's not new ongoing risk factors for Hep C infection, you don't need to do it. The patient does not have Hep C. If it's positive, then you're going to get a reflex confirmatory for a Hep C PCR RNA. If that is negative, then most likely he had a false positive antibody testing or a previous resolved Hep C infection. Remember, we have talked about in the past of spontaneous clearance, especially if the kids were exposed when they were infants and they could spontaneously clear the virus, right? Now, if it's positive, then you actually have a current Hep C infection, and that Hep C infection will lead to decide on the treatment, further workup, including genotype, and then counseling. Get social work involved because you also need to kind of find out what happened, right? Is this because of IV drug use? Is this because there's any risk factor, concern for sexual assault? What is going on? But either way, you have to provide counseling to the adolescent because this is something that they may not still comprehend enough of what's going on. So counseling to the families and to the patients are going to be very important. Once you have a genotype and then you guys have established kind of a course of action, then he will get treatment with the direct acting antivirals. And then they will get these treatments for 8 to 12 weeks and then repeat labs usually at 12 weeks to confirm eradication after we have finished the treatment time. So as you can see, the testing is going to be very similar as in the adult side. The thing that we are going to actually make sure that we are making or enforcing more is the counseling portion. Because we know that these kids who actually can be at increased risk of other STDs will need more support in that sense to prevent that as they become adults, this can become a more severe issue. Next slide, please. And so when we say we're going to screen them, we also have to consider what are going to be some of the implementation items to consider. One is you have to communicate to the patient. Even though they're adolescents, they are actually able to say, yes, I want to get screened. No, I don't want to get screened. So the screening has to be voluntary, and the patient needs to understand why are we doing it and what are the results going to actually confirm, and what does that mean if they have a positive result versus a negative result. They have to inform the patients about a Hep C infection, how it can and it cannot be acquired, what's the meaning of having that positive test, what are the benefits, and what are the harms of treatment. Remember, these adolescents sometimes will come to your clinic and said, "Listen, I want to get screening because I have had multiple partners. So I've had unprotected sex, or I've been using these." So they may actually come to your clinics requesting this type of screenings, and you have to actually make sure they know and they understand that this is confidential and what are the risks, what are the benefits of treatments, and what does that mean to have a positive and a negative test. You have to provide all the questions, and they are entitled to decline screening. That's for sure. But that's when the importance of your role as a healthcare provider comes in, like taking away the stigma of if I am screening, I'm going to get judged. Because if you talk to the adolescents, if you talk to this population, a lot of them will tell you, no, I don't have that. No, I don't do that. But they also know that there's a stigma associated with this. So as providers, as healthcare providers, we have to talk about them to kind of bring out that stigma out and say, hey, we're doing this because we want to take care of you. We want to make sure you're healthy. By keeping this confidential, we can actually do it and offer the best support with them. Have resources. A lot of the time, they're having issues with depression. There's homelessness issues in adolescence. Even though we don't think about those, they can be issues with that, where the parents where they don't have a good social support. So getting to talk to them about and having resources can make a significant impact on this children's or in this kid's life. Next slide, please. Now, we have limitations, of course, right? And one of the main limitations that happen is that we do need more studies. We do need to know exactly what's the actual epidemiology of infection, what's the actual effectiveness of DEA regimens in adolescents. Most of our studies that we extrapolate are coming from the adult world, right? And even though we know it's effective, we do have limitations when we present prevalence, when we present incidence, and when we talk about the importance of echo project in adolescence, right? Or how we can actually make sure that our message is hitting these populations. So that is a very significant limitation that we have in the pediatric world itself. But I think with the adolescents, especially, that limitation increases because, as I was telling you early, they are in this gray area where they're still not considered adult and they are children, But within the children, within the pediatrician world, they're considered a little bit older for those stuff too. So this is going to be something that in the future, I hope we can get more dedicated studies to look for incidence, to look at prevalence, to look at other cofactor risk of how we can actually implement these in the adolescent world so we can decrease Hep C, HIV, and other STDs as well. Next slide, please. And counseling. So I always put this slide because I think it's important. When you have a positive test, when you receive treatment, you have to tell them that their Hep C antibody will always be positive, no matter what. And they have to disclose as they become adults and they have to get retested because there's concern about a reinfection that they need to have a Hep C RNA PCR testing, that reinfection is possible, that the fact that you tested positive once and you're treated does not take away the fact that you can get reinfected, and that the treatment itself is going to be curative, but it does not prevent reinfection. So these are very important three things that I would highly recommend when you're talking with adolescents, when you're talking with adults, and when even you're talking with pregnant women or moms. Talked about these because this is going to have a significant impact about saying, hey, reinfection is possible. Safe sex precautions should be taken. Stop the use of IV drugs because reinfection is possible. Next slide, please. Now, when we are counseling, and a lot of the time when I have my adolescents who have tested positive for Hep C, a lot of the hour that I spent with them goes more in about counseling, goes more about explaining how was this transmitted, how can you get reinfected, and what do we do? So you have to recognize, or you have to actually make sure they understand the importance of that there are dangers of drug use. They think it's only IV. No, there are dangers in the use of all drugs use because these are going to lead to actually changes in behavior and start practicing. For example, do not practice safe sex can lead to that, or risk behaviors that can put them at risk for STDs, not only Hep C. Avoid sharing needles. I had one adolescent who told me, "Oh, but we just put some alcohol. We rub it in alcohol." And I'm like, "No, kiddo, we need to understand, we need to explain them, the issues like that, because they are getting all their medical information right now from TikTok. And so a lot of this information from TikTok is not accurate. It's coming up from like, we need to get these viewers. So we need to actually sit down with them, explain them, and talk to them about these safe practices. Avoid sharing needles. Or when you get tattoos or piercings, some of them say, oh, my friend did it, right? They didn't even know where the needle came from. So you have to talk about those things because they matter for children. They matter to the adolescent. Do not share personal items that may carry blood. We talked about nail clippers, razor, toothbrushes, things that are so simple that you're not thinking about it, but you have to explain them about. And the most important thing is no vaccine. We don't have a vaccine to prevent Hep C. I've had some adolescents who ask, like, is there any vaccine that I can get for that? Even though, you can see that in TikTok says, no, there's no, but they usually don't know. And so you have to explain them that the reason why is that we don't have a vaccine available, that we are trying to actually then prevent not only Hep C, HIV, but significant other STDs that can affect their life itself. Next slide, please. And then the recommendations that we usually give to parents that we're also going to give to the adolescents itself, right? That this is actually not something that is going to be transmitted by a casual contact, like a kiss, that they can participate in school and sports activity, that they can do any activities without restrictions, that universal precautions need to be taken care, especially avoiding exposure to razors, nail clippers, anything that can have contaminated blood. And in adolescence, I would definitely encourage them to talk about with their parents about, safe sex practices, avoid the use of drugs. There is this kind of, and I've been talking more and more with adolescents about like, oh, I only vape, I only do marijuana, or I only vape THC. And I'm like, they're not understanding and they're not comprehending that some of these drugs can be a gateway to the use of other drugs, right? And so they kind of minimize. So I think it's very important for all of us as healthcare providers, because these adolescents are going to be your future adults who are probably going to be dealing with this problem. So if we're able to identify sooner in life, treat them, counsel them, then this may be a better outcome as they become adults. Next slide, please. I think that was the last one. Any questions so far? I think I went a little bit over time, but as I get very excited talking about the adolescents because I do feel it's a group that we really they are still children, but they don't see themselves a lot as children anymore, but they are really not adults yet. So any questions so far of what we have talked?
All right. Well, if we don't have any questions, thank you so much, Dr. Alfaro Cruz. So we will have an opportunity, of course, towards the end of the session for you to ask any questions, or you can type your question in the chat at any time. But just for the sake of time, we are